We are live.
Okay. So, good evening, postgraduates, and welcome to this 50th episode of All India Postgraduate Teaching Program, an initiative from ARC, All India Ophthalmological Society. We call this PG program a PG program with difference because we here try to cover the uncovered aspects of other teaching programs like case presentations, journal clubs, OSCEs, and didactics are only on topics which are not comprehensively available for you in a textbook in a go. So today on the 50th episode, we have a didactic lecture on newer contact lenses, which has been asked as a long question in one of the MS finals. And it would be presented by my dear friend, Dr. Ajay Kulkarni, who is a trained cornea surgeon and is a director of Manorama Eye Clinic at Nagpur. My special thanks goes to Dr. Kuresh Muscati, who is a director, Muscati Eye Clinic, Mumbai, and he is also a past president of All India Ophthalmological Society. Dr. Nikhil Kandurwar, who is a cornea, phaco, and refractive surgeon at Netra Seva Eye Hospital, Nagpur, again a trained cornea surgeon. And Dr. Ankita Gupta, who is again a cornea and a refractive surgeon at Khanna Eye Center, Delhi. I'm really thankful, especially to Dr. Muscati sir, and of course to Dr. Nikhil and Ankita for sparing their valuable time uh, for our postgraduates. Now, without much ado, can I request Dr. Ajay Kulkarni to share his screen? Yeah, we can see Ajay.
Thank you, AIOS, ARC, Dr. Prashant, and welcome all my dear discussants, Dr. Muscati, Dr. Kandurwar, and Dr. Ankita. And as it is said that it is not about teaching, it is all about learning. All of us are still postgraduate students. Anybody who has done his postgraduation is a postgraduate student. So the topic is actually told by Dr. Prashant Bhavangure. I have certain disclosures to make. I don't have any financial interest because during the course of the presentation, there will be mention of few pharma companies and some names of the contact lenses. Do not have any financial interest. This is all purely academic intent. The basic idea is sensitization and awareness about contact lens developments and understanding the concepts before going in for practicing contact lens fitting. As you know that the market is studded with multiple options, and the idea here is to facilitate all of us or all of you to make the right choices. The world of internet is overloaded with information, so you have to decide how deep and far you want to go. So basically, this will be just an overview. All the details you can read further. Let me begin by acknowledging the contribution of this man, Leonardo da Vinci, who in year 1508 first came up with the idea of contact lens. And since that time, so much has happened in this contact lens industry. We need to remember that all said and done, contact lens is a foreign body which is put in the eye, and it is going to affect the anatomy and physiology of the ocular surface over a period of time. Cosmesis for many may be important, but safety comes first. And strict adherence to the good clinical practice and standard operating procedures as far as the caregiver is concerned and the patient is concerned is mandatory. And we all should always remember that above all, do no harm. What we know. So we know that 80% of light bending occurs at the corneal surface. So even a small irregularity degrades the quality of the image. And especially the irregular astigmatism which results is not amenable to full correction by glasses. And the vision can be greatly improved by achieving a smooth surface. And here comes the role of a contact lens. The basic idea is that we are converting an irregular surface to a regular surface. So what are we looking for when we are actually looking into contact lenses? So the patient needs or wants continually maintain sharp and stable vision in all conditions, the ease of handling of contact lens, prolonged comfort while carrying on the daily tasks, no induced dryness of eyes, ability to wear the lens through the night for many days, no major sight-threatening complications, and continuous improvement in the material, design, and the care products. So these are nothing but the attributes of a so-called ideal contact lens. So things to look at is we should know about the material, we should know about the design, the wettability of the surface, the oxygen permeability of the material, the water content, the resistance to damage and deposit buildup, and ease of handling and fitting the contact lenses. So before we go on further, let us divide the lenses available into these four categories. The first one to arrive on the scene was hard contact lens, which was made up of PE. Then the fluorosilicone acrylate arrived at the scene, and now what we have as RGP lenses. The soft lenses made a big inroad, primarily because of the comfort and ease of handling. They are made up of silicone hydrogels. And we also have a combination of these two materials in the form of hybrid lenses. That is the central part being PMMA and the peripheral skirt of a soft material. So let us begin with RGP lenses to start with. And then we'll go one by one and look at the other developments in the other soft contact lenses. So with the soft lenses arriving at the scene, RGP definitely took a backseat for some time. But then they came back with a bang with more versatility, because now these lenses are available for us to virtually fit any ocular surface. So this is just to show you that size does matter. We have contact lenses, the RGP lenses available in various sizes, and they are used for specific purposes. So what are the advantages of RGP lenses? Leave apart the part of the discomfort which is caused by the lenses, but it scores over soft lenses in so many other areas. First of all, it's a breathable material. So the oxygen carrying capacity of the material is far better than the soft lenses. It can be personalized, meaning thereby it can be customized according to the need of the ocular surface, the shape of the cornea for every individual. It does give you a superior quality of vision as compared to soft lenses, and it resists the deposit buildup. It is ideal for astigmatism. Cylinders as high as 4 to 4.5 diopters can be corrected by a properly fit RGP lens. It is cost effective because the lens, if properly handled, will go for a year or so. And it has very less risk of infection and inflammation associated with the fitting of the contact lenses. The average wear time can be as high as 12 to 14 hours a day. Over a period of time, there have been major game changers as far as RGP lenses are concerned. So these are larger diameter lenses and use of very high oxygen permeable material, that is dK by T, that is diffusion coefficient of this material. And because of improved manufacturing processes, the finish, the quality of the lenses has been increased. Traditionally, the RGP lenses, once they are on the cornea, they never cross the limbus. But with the large diameter lenses, now we are going beyond the limbus. So large diameter lenses typically range between 14 to 24 millimeters in diameter, and all possible things can be done as far as the design is concerned. They can be spherical, toric, reverse geometry, and the multifocality can also be incorporated in these lenses. There are two new types. One is the corneo-scleral lens, wherein the overall diameter is less than 15 millimeter. And when it is fit on the eye, it is partially supported by the cornea. And there's a mini or a true scleral lens, wherein the total diameter is between 14.3 to 16 millimeter, and it is purely supported by only the conjunctiva. It is basically aimed to wall the cornea. The basic idea is being the lens, the back surface of the lens does not touch the cornea and the limbus. So the comfort improves and basically also restores the ocular surface and protects it from the continuing ongoing injury because of the lens wear. This is a schematic which shows the fitting of the scleral lenses, wherein you can see an irregular cornea with irregular elevation and the lens which is nicely sitting on the sclera with a potential space between the cornea and the sclera, which is filled by a fluid which acts as a lacrimal lens, and this is how it corrects the astigmatism. This is a clinical photograph of a nicely fit scleral lens. What are the clinical applications of these large diameter lenses? So corneal ectasia, commonest being keratoconus, pellucid marginal degeneration, keratoglobus. These are other situations. Irregular cornea, especially when the eyes are damaged because of bad injuries. Sometimes there is extrusion of lens as well. The patient is rendered aphakic. So if you have a irregular corneal surface scar with ectatic cornea and aphakia, in these lenses can take care of the ametropia, which is resulted because of loss of lens, the crystalline lens. And moderate to high spherical errors and astigmatism can also be countered by these lenses. What are the benefits of large diameter lenses? So first of all, comfort, because we know that cornea is the most sensitive tissue. And as compared to the cornea, the conjunctival sensation, the sensation of the conjunctiva is not that as compared to the cornea. So the lens which is sitting on the conjunctiva is likely to be more comfortable. Since the fitting is very snugly along the ocular surface, there is no invasion of dust or debris underneath the lens. The dryness of the surface is taken care of. It offers you a crisp and sharp vision, and it's the best option to correct astigmatism, especially the higher degrees of astigmatism, because of the rotational stability and lesser movement of the lens after it is fit on the surface. There are certain fitting issues. As we just saw that the lens diameter is typically more than the usual lenses. So in the initial part, the patients don't find it very easy to insert the large diameter lenses. So there are people who have been, the experienced lens wearer can insert the scleral lens just the way they insert the RGB lenses. But there is a definite system of using an inserter for these large diameter lenses. Most important is once the lens is on the surface, after half an hour, the fit is assessed. And it is important to ensure that there is a wall, that is a space between the back surface of the lens and the corneal surface of around 125 to 150 micrometer when the overall diameter is less than 15 millimeter. And it can be as high as 200 to 400 for the larger diameters. If the vault is not proper, then you will land up with what is called as a tight lens syndrome, wherein the inside of the lens and the outside is shut off because of the edge is very snugly fitting to the conjunctiva, and the inflammatory debris, and gets sequestered underneath the lens, and which can result in inflammatory episodes affecting the ocular surface. This is to show you the inserter, which basically works on the principle of vacuum, just like a silicone or rubber like hollow rod. Just press it, create vacuum, and the lens nicely sits on it. And once the lens is delivered in the eye, just by pressing it, the vacuum is released and the lens settles down on the ocular surface. So while we are on the RGP lenses, let us talk about two major areas wherein the contact lens, use of contact lens is very, very important. One is to actually negate the effect of the disease process, and the other being myopia, especially the progressive myopia, wherein we have a chance to modify the natural history of the disease by fitting specially designed contact lenses. So when it comes to keratoconus, in the early part, a traditional soft or a standard GP lens will work. When the cone starts becoming more moderate to severe cone, we need special lenses. So either you can consider a rose scale lens, which is nothing but lens which has multiple posterior curvature on the posterior surface of the lens, which is designed to fit the irregular surface of the cornea. We also have the option of a hybrid lens, wherein the central optical portion is of a PMMA material and the peripheral portion is of a soft lens material. And the scleral lenses, which we just talked about. And there is another system called as piggyback lenses, wherein first a soft lens is fit on the cornea, and over and above the soft lens, an RGP lens is fit. But by and large, a properly fit rose scale lenses or scleral lenses are good enough to take care of almost all the cones. If the visual axis is clear, if there is no central scarring, it is a good idea not to subject these patients for surgical correction of keratoconus. So higher the elevation, larger will be the diameter. This is the schematic which shows you. These are just to show you how the lenses look like: the GP, the routine GP, the hybrid lens, and the scleral lens. Now, because of increased demand and the important factor of the comfort with the long duration of lens wear. Rose K2 lens now is available in softer lens variety also. So there is a Rose K2 soft seal design, which has a toricity and aberration control mechanism on the front surface, and the back surface is loaded with aspheric optic zone. It offers you edge lift control, prism ballast stability, and reverse geometry configuration. So maintaining the advantages of a RGP lens to correct the vision in keratoconus patient, now this option of a soft contact lens is also there. So moving on to the next condition, which I just mentioned, apart from keratoconus, is progressive myopia. So this is a technique which is becoming very popular these days. It's called as orthokeratology. It is nothing but a technique for achieving central corneal flattening by overnight wear of contact lens, typically the RGP lens. And this is used for temporary correction and slowing down the progression of myopia. The patient wears the lens during the night, but during the day, there is no lens wear. The special design, which is contrary to the conventional design, all of us know that cornea is a prolate structure, meaning the maximum curvature is in the center, and as you go towards the periphery, the cornea flattens. This is called as a prolate design. And the oblate design is when the center flattens and the mid-periphery bulges. This is commonly seen or typically seen in patients who have undergone RK surgeries. So this is basically considered while designing this lens. So this is a special design which will keep the central cornea pressed. Usually it requires around 3 sets in trial to achieve at the final desired fit. And once we achieve a desired fit, this lens is one for a longer time, and this lens is called as a retainer lens. So first we achieve the flattening, and then we have to retain that flattening. It has been reported that 88 to 95% of the patient achieve an uncorrected visual acuity of 6/9 with orthokeratology. Well, nothing is foolproof, so it also has its own issues, especially the increased risk of corneal staining. This is the commonest seen clinically. If you just put a fluorescent stain on the corneal surface, you can see multiple punctate stain areas. Very tightly fit lens can result in significant amount of corneal edema the next day. And there is definite but low risk of microbial keratitis, which has been around 6% in 10,000 patients. The good news is that there is no significant endothelial cell loss has been reported so far in any of the studies. This schematic shows what I was talking about, the reverse geometry lens. Here you can see there are 4 zones as you go from center to periphery. The zone 1 is the central optical zone. The zone 2 is the reverse return zone. The zone 3 is the landing zone, where the lens is touching the cornea, and the 4th zone is the peripheral zone. This is how a typical lens fit would look like. The central zone, the zone 2, 3, and 4. When you put the lens on the eye, the best way to assess the fit quality is put a fluorescein and then examine under slit lamp. So the central area, which does not show the green color, is the area where the lens is pressing the central cornea. Then there is a ring of a green color, wherein there is elevation of the lens, and the mid-periphery, again, there is bearing. Bearing is nothing but the lens is sitting on the cornea. And the edge again shows the fluorescent. It means that the edge is slightly lifted from the surface. So this is a typical fluorescent pattern which will be seen in this type of lenses. This is the routine RGP lens. When we fit this lens on the eye, this is how the fluorescent picture would look like. So herein, there is diffuse distribution of fluorescent in the larger central part, followed by a thin area of bearing where you don't see the fluorescent, where the lens is touching the cornea. And then again, at the edge, you see a ring of fluorescent, which means that the tear film is freely getting exchanged underneath the contact lens with every blink. If you compare and contrast, this picture will show you in the center in the routine RGP, you see the green color, but in ortho-K lens, the center, you won't see the green color. So after looking at these new developments in the RGP lenses, especially people have used 2 parameters. One is they have increased the size of the lens. so that it is not touching the cornea. And the second is improved materials, wherein the oxygen permeability of the material has been increased. So these two changes in RGB material has gone a big way in treating our patients with ectatic disorders as well as the progressive myopia. Now let us see what new developments or new lenses we are having at our disposal when it comes to soft contact lenses. So again, to divide, depending on the replacement schedule, these lenses are labeled as conventional daily use contact lenses. The same lens can be used for a year or so. Then we have frequent replacement lenses. These are the disposable variety, wherein you have a daily disposable, a weekly disposable, a monthly disposable, or quarterly disposable. So depending upon the frequency of the replacement, these are labeled so. Any lens which is worn overnight, by definition, is called as an extended wear lens. So this is very important point and often overlooked by the practitioner as well as the patient. So a callous attitude towards the wearing time sometimes can land the patient up in problems, especially the infectious keratitis or other inflammatory events. Only those lenses which have been approved for extended wear should be used overnight. Normal routine lenses should never be worn overnight. Then we have toric lenses, because initially the problem with routine soft contact lenses was inability to correct higher cylinders. But now up to 2.25 SIL can be incorporated in the cylinder, and when this lens is put on the eye, up to 3.5 cylinder can be corrected. Those who have been using contact lenses for many years from the age of 20, now that population which has now reached 40, now they need a presbyopic correction, and they are not willing to use glasses. So the contact lens industry has designed lenses accordingly. So we the way we have bifocal and multifocal glasses, we also have to our disposal now bifocal as well as multifocal contact lenses. Many people are not happy with the eyes of the color of their eyes. So for them also, there are certain products which is labeled as colored contact lenses, wherein you can change the color of your eye. More important, therapeutic lenses has a big role in a lot of corneal surface pathologies, and these are also available in different diameters. Many people are not aware that a very large diameter lens is also available, especially used for bleb leaks. So the diameter can be as large as 16 to 18 millimeters, which covers the area of the bleb and can be used in the early part of the trabeculectomy procedure, where there is shallowing of chamber and the reason being a bleb leak. And there are other lenses which are cosmetic lenses. Patients who have opaque cornea, no visual potential, and patient is not willing for any surgical correction for cosmesis, this is a good option for hiding the opaque cornea with cosmetic lenses. There are two basic designs. One is the clear pupil, and if there is some amount of central cornea clarity and the vision potential is good, then the clear pupil lens is used. But if the vision potential is not good, then a central black pupil of various diameter and 3 different tints of iris brown pigment can be used. And in the pipeline, the research is going on to look at, can the lens or the soft lens be used for other purposes, not only for vision correction or cosmesis. Yes, it can be used for continued or sustained drug delivery to the ocular surface. So there are different methodologies which are employed by the manufacturers to achieve multifocality. So these are the 3 methods. That is, one is the concentric alternating ring for the distance and near vision. Then the aspheric design, all of you are aware of that. And the third one is the segmented design, just like a bifocal glasses. You have upper 2/3 for distance vision and lower 1/3 for near vision. So what is new in daily wear lenses? Now, this lens which has been launched in 2023, My Day Energies by Cooper Vision, it has an aspheric design. It uses aquaform technology, and it is loaded with 0.3 diopter boost of power. And it also has inbuilt UV blocker. So these are 4 value additions to these lenses, what actually these additions are achieving. So first of all, it is reducing the eye strain, especially the digital eye strain, and it maintains focus. Somebody who is working on the screen, focusing on the screen, and suddenly has to look at a far distance, the focus is not lost. And it improves comfort because of aquaphone technology. The hydration is maintained, and this is a nice addition for the population because of all walks of life. Now you can't escape the screen. Most of the professions demand a lot of exposure to the screen, and for these individuals, this is a new lens which is now available in powers from +8 to -12 diopter. Then there is some new product from Alcon in the toric lens segment. This is called as Total 30 for astigmatism. They use what is called as water gradient material, biomimetic Celigen technology. So this is basically a 1-month replacement lens, and it resists bacteria and lipid deposits on the lens. So the lens is absolutely fine and very clean at the end of 1 month of wear. What Alcon call the 8x4 design, which is basically to improve the stability of the fit, because these toric lenses, they will always have a rotational instability. Now, this lens, once it is put in the eye, takes around 60 seconds to achieve its final fit, and it rests within 3 degrees of the ideal rotation. Most of the time, what is called as first fit theory. So the first lens which you fit on the eye is usually the final lens fit. So 95% of the times, you can fit the first lens, which becomes your final lens when it comes to toric soft contact lenses. So these are the methods which are used in the manufacturing of toric lenses. Prism ballast is nothing but the inferior blue zone, which you see the thickness of the lens is more there, the weight being higher. Whichever way you put it on the cornea, because of gravity, this segment comes down. So this ballasting can be segmental, this can be all around, and this can be truncated. So these are various methods which have been used and employed by different manufacturers to achieve a stability of the toric lenses. So after looking at these 2 new lenses in soft lens segment, let us now move on to the use of contact lenses for therapeutic purpose, wherein the contact lens is impregnated or soaked in medication, which is continuously delivered to the eye. So LLBMT1 lens is by Mediprint Ophthalmics, and this is a drug-eluting contact lens for treatment of glaucoma and ocular hypertension. It is now currently undergoing phase 2 trial. This is basically for deciding how much should be the dosing dose of the pimetoprost, which should be incorporated in the lens. And another lens by the Therapeutic, again, is a bandage contact lens, because we want this lens to be on the surface of the eye for a longer period of time, till the time the whole drug is leached out. So it uses a polymer which is called as methafilcon, and there is an encapsulated drug polymer ring in the periphery of the lens. There are 2 lenses. One is tetra lens. This is used for post-operative pain after C3R, after PRK, LASIK, and the another is a DEXA lens, which is used for the treatment of PVR. Glint Pharma is another company which has come up with a lens called as Moxi lens. They basically incorporated drug delivery technology in the commercially available daily disposable lens. Now, this is going to be the game changer, because you don't have to invest in a very high-end contact lens, because a commercially available daily disposable lens can be easily used. You just have to have that addition of the drug to this lens. So far, moxifloxacin, dorzolamide, and timolol have been tried, and the results are quite promising. Now, a word about myopia control lenses. We talked about orthokeratology, where primarily the lens which was used was a RGP lens. Now, J&J have come up with a new lens called as Ability one-day soft therapeutic lens, and it uses a different lens design. They don't use the traditionally designed concentric ring dual focus, which is used for prevention of myopia. Now, this lens can be used in children aged 7 to 12 years, and if the myopic refractive error is in the range of minus 0.75 to minus 4.5 diopter and cylinder less than 1 diopter. This has shown a lot of promise, and almost 68 to 70% cases, it has shown to slow down the progression of myopia. Now, do we have anything for patients who are colorblind, especially deuteranopia, which is red-green color blindness? So this is a prototype lens. This is called as deep red tint X-chrome lens. It basically, after it is put on the eye, it alters the color wavelength to remove the deficient color. And that is how it works in colorblind individuals. Now we'll go on to the cosmetic lenses. So what's new in cosmetic lenses? We have different methodologies of making the lens colored. One is the transparent tinted lens. The second is dot matrix computer generated. And the third is custom hand painted. Of late, especially in the Oriental countries, the limbal ring cosmetic lens is making a lot of waves. The recent data from Singapore and the other Oriental countries said that around 40% to 50% individuals are going in for this limbal ring cosmetic contact lens. What it does is basically there's a pigmented ring which is at the limbus. When the lens is on the eye, in the limbal area, there will be a pigmented ring. So this ring gives you an illusion of increase in the size of the eye. So people who are not very happy with the small eyes, there it has picked up in a big way. So you name the color and they are available with us. So these are the different colors and hues which are available in the market, but there is no limit to craziness when it comes to cosmesis. In fashion industry also we have seen, and these are the lenses which are called as crazy lenses. You can look at the designs, you can look at the colors and whatnot. This is just to show you where things are heading. So when we are talking about the new contact lenses available to us, it is not complete till the time we are also looking at the complete care of the contact lenses, which includes the solution which are used and the care, the contact lens case. So these two products by Bausch & Lomb, BioTrue Hydration Plus, which is nothing but a multi-purpose solution which is used for cleaning, rinsing, disinfection, and increasing the wettability. Only one solution is sufficient. And BioTrue Hydration Boost Rehydrating Drops. So these are eye drops basically developed by Bausch & Lomb, which can be used by patients over the contact lens. Now, traditionally, we have been using HPMC or CMC over the contact lenses, but this is specifically designed to be used for contact lens wearing population. It is important for us to emphasize that no lens should be washed with water. And there are people who use saliva to clean the lens, to make it hydrated. So all these things, they are traditional methods, all non-scientific methods. So it is our own responsibility to emphasize on the patient that scientifically proven, properly designed, multi-purpose solutions are available for taking care of the lenses. Interesting concept of impregnating the contact lens case from the inside by silver nanoparticle, which has been shown to be preventing the buildup of the bacteria and the contaminants. So this is very important, but most of the time, the source of infection associated with contact lens is a poorly managed contact lens, where the subject is basically topping up the solution and not exchanging it properly at the end of 3 to 5 days. So there is a lot of dirt and the slime builds up. There is a formation of biofilms, and these bugs later on get transferred to the contact lens and are responsible for infection. So it's a complete comprehensive coverage when we talk about contact lenses: the material, the design, the soft, the RGP, the solutions, and the contact lens case. So there have been improvements in all the areas which are associated with contact lens wear. So the world we see depends on the lens we use. It is so true. So don't lose the old contact while creating the new, because there's so many new things have been coming up in the market. But our age-old RGB lenses is still my favorite because it can take care of so many irregular corneas. So thank you for your kind attention, and I wish that you make all the right contacts. Thank you very much.
Thank you, Dr. Ajay, for comprehensively well covering the whole topic. It was such a topic, but you have so lucidly covered all the aspects. So I can invite all the discussants, Kurish Maskati sir, Nikhil, and Dr. Ankita to join us and can add upon certain things what you think must be important for the postgraduates. Why not from the boss, Dr. Maskati sir?
Can we stop screen share?
Yeah.
Yes, Ajay, truly enjoyed I felt like a postgraduate again, absorbing every word from the teacher. I think it was quite comprehensive and covered everything. I am a long-term user since almost 30 years of the scleral lenses, having picked it up from Chandrasekhar Chavan and then gone to Boston, where Perry Rosenthal taught us the intricacies of the scleral lenses. It has gone through a lot of name changes, Pros lens and BOSP and all that. I don't even know what the final name today is. But yes, scleral lenses have been game changers. And as you correctly said, I think the drug-eluting contact lenses are here to stay. There's another J&J one which is in the market for allergic conjunctivitis as well. So the drug companies are teaming up with the contact lens companies and putting in different contact medicines in this. It is possible post-cataract also that you wear a contact lens for 15 days or so with the right amount of antibiotic and steroid and don't need to put any drops. So the future is very bright, but as you correctly said in the last, don't throw away the old for the new. I have several RGP users who are extremely happy. And when I tell them that now everything is available you were wearing RGP because you had -2 cylinder, and now I can give you the same thing with a soft lens. They're very reluctant to shift. They're extremely happy. And as you said, there are people 10, 15, 20 years users who have shifted to the multifocal lenses as well. So the only issue, the only one word to the postgraduates is when you finish your exams, when you come out into the big world of practice, don't leave contact lenses to optometrists. You are the one who will motivate the patients. Patients will come and listen to you. You are the one who will tell them, yes, you can go in for contact lenses. The mother will say, oh, but my child is too young. See, initially when I was fitting contact lenses, I was not fitting it in anyone who was not going to college. So my criteria was that while you're in school, glasses, when you go to college, you're more conscious of your cosmesis and you're more able to look after the contact lenses. And so we'll give it to you only when you're 15 or 16. But that's no longer true. My age limit has come down for prescribing contact lenses, even for children, not necessarily for myopia control, but it is our realization that younger and younger kids are also cosmetically more aware than we were when we were kids. And since the contact lens fitting is become so much simpler, only thing is you need motivated child and motivated parent. Unless both are there, don't give for children below the age of 10 or 12 is the thing. Because sometimes, conversely, Ajay, I find the parent is very motivated and the child is not so motivated.
Yeah.
Parent says, please put a contact lens. My child number is increasing, and the people are teasing him because of his the thick glasses. But the child is blissfully unconcerned. He's not even listening to the conversation. If that is so, it's a big no for me. I will not prescribe. And if the child is keen and the parents are very casual and careless in their attitude, which I find, they are not interested when I'm trying to explain how to look after hygiene, and they're not interested. Again, it's a big no for me, because the child at 10 or 12, needs the support of the parents to nag the child, to see that the case is clean, to see that the lenses are put. So unless both are on the same page, no. But otherwise, I think you can safely prescribe contact lenses, and the fittings have become much easier than when I started fitting decades ago. Previously, we used to talk the child through the thing that, now I'm going to remove the lens and now I'm going to put it in your eye and you won't feel anything. And, a whole drama, like a Hindi story I used film. And now I'm chatting with the parents. I distract the child and I just pop the lens in. Child doesn't even realize that a lens has been fitted. Then I tell them, look how easy it was. So a lot of things have changed because technology has changed, lens materials have changed. We didn't go into details of the various materials, I think, Ajay, but the materials have changed, and that's why comfort has become so much better. Thank you.
We will move on to the next discussion, but there are a few questions which I will just ask, which have been put forth by a few of the postgraduate. Sir, how do we go ahead of putting a contact lens in an infant, as mentioned in the child, if there is unilateral amla, means myopia or aphakia? That's what I think. How do you calculate what? That's what I probably he wants to know. Sir,
So,
anyone can answer?
I had, when the Silsoft lenses arrived, I had a good opportunity to do pediatric aphakia fittings. Very young children where we are not able to put intraocular lenses because of the age. We were using Silsoft. This is basically again a silicone hydrogel lens. And believe me, the mothers are so motivated. Basically, you have to teach the mother to how to put the lens and take care of the lens. Because the child, if you are talking about infant, obviously infant is not going to handle the lens, but the mothers are very well motivated. So basically, you have to give do a refraction, and then there is a conversion factor. That is how it will decide the which power of the lens to be prescribed. And as the eye grows, if there is change in the refraction, we have advantage of changing the lens and still the child sees the same, which is not the case when we the intraocular lens is put and the child develops myopia after the surgery. So
you need a general anesthesia for contact lens evaluation in such?
No, not required.
Not required. Okay. I think we can continue with the discussion. I'm scrolling through a few of the more questions. Dr. Nikhil?
Yeah, so first of all, Ajay sir, it was outstanding overview of all the contact lenses, and it's very well summarized because the scope of contact lenses has grown so big that it has become a separate specialty nowadays. And adding on to the points, I know there are limitation of time, so we cannot just keep on bragging. But you were talking about color and cosmesis contact lenses. Recently, I've come across a colored RGP. So there was a central opacity, and it was a macular grade opacity, and we know that how RGP improves the vision, and it served the dual purpose. So even the colored RGPs are coming up, so taking care of both vision as well as the cosmesis. And coming across just for PGs, they must know that there are different kind of solutions for different lenses. So soft contact lenses solution and gas permeable lenses solutions are very different. So please go through the compositions in detail, and they should not be mixed because recently come across a patient had a lot of burning because of soft contact lens was immersed in a GP solution. And one thing I want to really add about PGs is it is really a life-changing thing for advanced keratoconus patient. These days, the need for doing DALK has gone really down. The threshold of performing DALK in last 5 years, just because of the development of excellent designs of neoscleral contact lenses, the number of DALKs we are performing now has greatly reduced. And the kind of vision, like my teacher during my fellowship, he always used to quote one thing to the patient: nothing can give you better vision than a good fitting contact lens. So that's what I have been seeing patients who are having hardly counting finger visions, they come back to 6 part 6 by 9, and they come to you next visit they come to you driving. So this is how they are real game changer. And further more developments are the way like the dentists take impressions for the prosthesis. Nowadays, the similar impressions are being tried for very well customized design for contact lenses, and a personalized and customized design can be made. So these are few additions I would like to add to this topic. Thank you.
3D printing, you mean, for the
Yes,
contact?
yes, almost.
I would like to just add one small incidence when it comes to cosmetic lenses. So I had a cluster of 13 infective keratitis cases. These 13 girls, they were residing in a hostel. They pulled in money and bought all the colors of cosmetic lenses and decided their days, and they kept on swapping the lenses. So one individual developed the infection and all 13 were infected. So for us, it is very important to, even this is now my part of my counseling, that you don't have to share these lenses. Please do not share these lenses with anyone.
One question again there is, so how do you derive the power, means contact lens for keratoconus? I think Ankita or Ajay, anyone can take it. The question is framed like this.
How do you derive the power of contact lens for keratoconus? Basically, keratoconus lens fitting depends upon the trial lens fitting. So you first get a topography done that will help you in deciding the initial lens fit. So you can start your fitting on average K, or there are different fitting philosophies. There is like central touch philosophy. There are 3-point touch philosophies. There are different techniques of fitting the lens. But by and large, you have to see that the lens remains in the center and moves with the blink. So it is not stuck to the cornea, or it doesn't move excessively. The best way to see the fitting is put a fluorescein after you have put the lens. And if the fluorescein tells you that it's a tight fitting lens, you have to loosen the lens by increasing the base curve. If it's a loose fitting lens, you start reducing the base curve and make it more tight, so that it is in the center and moves nicely. The average movement of the lens, nice central fitting, good fluorescein. This will be the fitting character. The first, you have to achieve a good central fit, then the peripheral fit. Now we have the option of customizing the central as well as the peripheral fit separately. Once you achieve a ideal fit, then you over refract on the lens and add that power, whatever the patient accepts, over refraction, and that power will be added to the final lens. So that is how it is done. The companies give you a 1 month period of any changes if required in the fit and the power, and this service is provided free of cost.
Okay. One question is there on presbyopic contact lens. How do we go ahead with it? It's a very...
There are different ads available to your distance correction. Depending on your need, you can decide how much ad you need for the near vision.
Okay. Dr. Ankita, you have been silent. You can...
Yes, thank you, sir, for giving me the opportunity to be part of this AIS program. I would like to add certain points, like nowadays we are seeing newer indications for the use of scleral lenses in my OPD, like the post-archectasia patients who had got multiple cuts earlier, and they are now turning up for cataract surgery. Already deriving the accurate ILPAR is a big task in those cases, and they are having ectasia of about along with irregular astigmatism, like it is very difficult to manage and give meet to the demands of such patients. So scleral lenses are giving good visual outcome and are very comfortable in these such cases. And also the post-LASIK ectasia patients and post-PK patients also, we can see good visual outcome in these patients. And certain patients, I think in ortho care, I would like to add that there are some teenagers like who are basically not fit for LASIK surgery, and they don't want to daily wear the contact lens, especially like if they have to go for a swimming competition in the school or something, they can wear an overnight ortho care, and next day they would be comfortable for the school or whatever social parties and all, because they are not fit for LASIK surgeries because of age. Uh, Rest, I would like to add that, as sir has rightly mentioned, that we should preliminarily examine the eye for all the risk factors, whether the patient is motivated, or there is some blepharitis, MGDs, frequent eye history. Then we should avoid giving contact lens to such patients because of risk of catching microbial keratitis. And uh, also, I would like to say that there are many advancements, like as sir mentioned about the aspheric lenses, and there are some systems which can mold even more faster, even correcting more about -10 diopters. GOV extreme system is correcting -10, it is saying, but I'm yet to try on it. We can try ortho case in kids who have family history of at least myopia in one parent, or are having fast progression of in more than one diopter per year. I think it has a promising future. At least we cannot treat completely the myopia. We can delay the presence of high myopia in future in such kids.
Yeah, there is one question on orthokeratology.
I just wanted to interrupt Prashant. Ankita mentioned in passing swimming. I just want to caution PGs that when somebody asks you, can I wear the contact lenses while swimming? I will wear swimmer's goggles. The answer is a big no. So please, if there are swimmers, counsel them that you get very cheap swimmer's goggles on Amazon. No financial interest in Amazon. I wish I had. But you get swimmer's goggles with -2, -3, -4, all sorts of powers available. Or your friendly neighborhood optician can grind a power in a regular and give you swimmer's goggles, which will be very comfortable while swimming. But no matter how tightly fitting, if you want a contact lens, the water is going to go in at some point and it's going to foul up your eyes. So strictly
I
no
think
contact
ortho K
lenses.
can be used. I was suggesting ortho K in those cases. Ortho K at night time wear. And
Perfect. Yeah. And another indication I forgot. I do a lot of Boston keratoprosthesis, and in all of them we need those soft, large diameter scleral lenses as a lifetime bandage lens, 16 to 18 mm. So we're using these to cover, and every 2 months we are supposed to change because of financial reasons. We normally change the lens every 3 months. So they wear it for 2 to 3 months, then they throw it away and wear a new one. Thanks.
Yeah, Dr. Nikhil, then I will ask the question. Nikhil first.
So when Ajay sir rightly pointed out that after prolonged wear of these orthoke lenses, we get that punctate staining in some cases. So for swimmers, it's a risky factor. We are actually allowing the bacteria to enter through the bridged epithelium. So I really don't find it's a I usually discourage for swimmers to wear this kind of contact lenses. And another one, the one thing for PG especially. So the very good use of RGB to know the BCVA before planning any further procedures. Like even for opacities, are we planning dark or any kind of procedures on the eye? So there had been certain cases where if the cylinders are high, even with pinhole, you don't get the BCVA, but you put the RGP, you get at least one line better improvement over pinhole. So PGs can try this just because it's more because of aberration control, I think, and RGPs are good means to test the best corrected visual acuity over spectacles and pinhole.
Okay. One question let me ask before we go ahead with the discussion. It is framed as orthokeratology, sir. How much is the maximum power it can correct and how many hours it maintains? And does it lead to myopia control? Anyone can take it, sir. Muscati, sir, or Ankita, whoever.
New orthokeratology lenses have come up, which earlier ones used to correct like -4 with and cylinder of about 1 to 2 diopters. Now we have which correct +5 diopters to -10 also are coming up. But these lenses are good for myopia control also, along with like if you want vision to be stable next day, we want overnight minimum of 7 hours of sleep time should be there with the ortho K lenses. And but this should be done consistently if you want a myopia control to be done. It is not that you are wearing half time in the week, 3 days in a week, and you're leaving it in between, then the results won't be good. Also, if we want like the next day, it should be clear. It depends on the power which you are have. If suppose it's a 1.5 minus power, then probably if you wear 1 day and 2 day, then the vision would be clear. If the power is more like -6, -4, then obviously you will have to wear about regularly about 10 to 15 days. Then the effect comes more better. And we can assess this more betterly by doing a corneal topography also, in which we will see the central flattening and mid-peripheral steepening pattern. I think Nikhil sir or Muscati sir can add.
How many
Yeah, that's
hours it
fine. Yeah.
maintains? That is
Eight,
what.
So
8 hours every night,
Ortho-K
7 to 8
basically
hours.
came in first just as a form of myopia treatment. It was quite by accident that it was discovered that it also can control myopia. So that is something in the last decade, but otherwise Ortho-K has been around since several years, just as a form of myopia treatment like spectacles. Yeah.
I think the question was how many hours does the myopia is taken care of after orthokeratology? That's
The
what
full day, probably the full day it can take
12
care.
hours.
Well, basically, 10 to day working hours, basically 12 to 14 hours.
So sometimes it depends on the power also.
As
And
Ankita said, it's very power dependent. Yeah.
And in certain cases, if it is just used for myopia, not for myopia control, and just for refractive correction, and once you achieve that, so after a few days you can use it alternate days also and still get zero power.
In the lower powers, yes.
Yes.
Yeah.
Great. Any more points?
I think
Nikhil,
we have exhausted the
think,
poor
yes,
PGs.
just I think some uncommon complications of scleral lens where like if you have you can see we should check first of all there is no blanching of conjunctival vessels like when you are doing a contact lens scleral lens fitting after assessing the clearance we should second test it in all the quadrants, superior, inferior, middle, temporal, and nasal. Also, if there is a patient of glaucoma in which you with keratoconus, in these patients nowadays there are new scleral contact lenses which have fenestration channels, so that because it is said that scleral lens might induce a increase in IOP. So there are some newer models which are coming with fenestrations, so that can help. And I think. Also, we should see that whether there is some patients might have midday fogging with the application of scleral lenses. So they may need to remove them and then reapply them by changing the solution.
Very dry eye patients like Steven Johnson's who are wearing these scleral lenses to prevent the trichytic eyelashes from rubbing against the cornea or to prevent lid viper epitheliopathy. Some of them, because their eyes are so dry, they accumulate a lot of mucus and debris within 4 hours also of wearing the lens. No harm at all. We tell them to remove it and clean it and put fresh saline inside and wear it again for the next 4 hours. It's still the most comfortable thing that they can do for a bad Steven Johnson. I've seen Steven Johnson patients with finger counting improving to 612 and 69 with the scleral lenses, and they're extremely happy. I've had patients who have to remove it every 3 hours. That bad as Steven Johnson, but it's part of the game.
okay.
So I would just like to add for PGs, I would urge all the PGs to go to their contact lens departments and go through all the trial sets and see how they are divided, what set of lenses are available, and how they are designed and how they are customized. So unless they see it practically, it won't be easy to just read and just analyze about.
No, not only that, every PG must put a contact lens inside their own eye. Wear a contact lens, put it on for half an hour, because how can you explain to a patient, for example, I am not a contact lens wearer, I cannot tolerate a contact lens, but when I was a PG, I wore a contact lens and removed it. So then you know exactly the practical difficulties that they have. You can show them videos and everything, but if you have done it yourself, I would just urge every PG at least once in their lifetime to wear a contact lens and remove it, under guidance, of course.
Right. So I think we have almost, it's 9. We are almost through with the time. I think, shall I call it off now?
Yes, yes.
Yeah, sure.
So thank you, Ajay, for wonderfully preparing the topic for our all postgraduate. It was really very lucid talk as well as quite elaborate. And of course, all the special comments from Kurishma Skatti sir, Nikhil, and Dr. Ankita for spicing it up and adding it to it. I'm really thankful on behalf of all the postgraduates of our country who are watching this program for making it so lively and interactive. Thank you once more. And postgraduates will be meeting on the following Thursday again at 8 p.m. And that time it is going to be the case presentation for you. Till then, it's time for us to say bye-bye. Good night.
Thank you.
Sir.